Test, test, 1, 2, 3. Test, test, 1, 2, 3.
should. Okay. Too worried about it. I'll get used to it.
Hey, I'll be sitting there all day. Now, this is the you break you buy situation. I said, this is the you break you buy situation. Or if I didn't play the other reason why I got that. Commissioner?
She went to
You want to, you sure? I'm sure. All right. You put your hand on that Bible and let me actually give you that copy.
It's another Aggie.
Is there something I'm supposed to do different?
Speak very slowly. Speak slowly, Robert, very slowly.
Do solemnly swear that I have not directly or indirectly paid or offered
Well, first of all, good afternoon, and thank you all very much for being here. I guess I'd say Happy New Year because this is actually the first official board meeting we have had in 2019. Obviously, there's been committees that met with members during January. A lot of work has been done, and I thank those committee chairs and members of those committees. So at this time, again, thank you all very much for being here. I'd say Happy New Year and Happy Valentine's, but we appreciate you being here. We will now call this officially to order at 1:10. So at this particular point in time, I'd like to call Ms. Leanne Franklin up, chaplain, and please, after that, we will please join me in a pledge of allegiance. Thank you. Leanne.
Thank you. Will you please join me in prayer? We gather together today on this blue sky, warm sunshine day, and we thank you for this new day. We thank you for all things new, for our new board members and all those who support them, for fresh ideas, for new possibilities, for all that we are creating together. So we ask that you please focus our efforts, ignite our hope, inspire our hearts on this day of love. Just join our hearts together and be with us as we create new things and new possibilities, and all for the good of our community that extends far beyond these walls. Thank you, thank you, thank you for all things new. In your holy name we pray. Amen.
Amen. Thank you, Leanne. I've been advised no one had signed in to speak today, so they'll move forward to item number 4 of the agenda, which is the approval of the minutes which were provided previously for the December 13th meeting. If there's any discussion or corrections, we'd consider them at this time. If not, I'd entertain a motion for approval. Have a motion by Dr. Weber, second by Reverend Emerson. All those in favor say aye. Aye. Opposed, no. Thank you very much. And I'll take us down to item number 5, and it's, I guess it's my board chair. And again, I think, Leanne, you said it very well. We're thankful for our new board members. So again, I'll take this time. I won't read the bios. As you know, as board of manager members, you received an email on both the backgrounds of Amanda and Zim, and obviously they bring a tremendous amount of experience and expertise. So we're welcome them and look forward. I will be getting with each one of you. As you know, if you believe that story that they told you, and JD's still in here, but when you were appointed, they probably said, "Oh, don't worry about it. This is only about an hour or so a month." They lied. I will tell you, we have a lot of meetings and we go to a lot of things, but the commitment to this board and the mission of this district and what goes on within the walls, not only this hospital, but throughout the entire Tarrant County, what this hospital and the mission does, it's not about the money, because there isn't any, but you'll certainly give you time. So thank y'all for agreeing to serve. And other than that, I think we are going to have a little bit of an extensive executive session today, so I'll advise everyone at this time when we do go to executive session. And then I guess the last thing I will mention is the Texas Hospital Association's annual conference is coming up next, I guess it's Tuesday and Wednesday. And I know right now Ms. Montgomery and Mrs. DeBose and Reverend Emerson are planning on going to that. I've certainly attended that in Austin in the past. Unfortunately, I have a job and have another board meeting next week. So I will probably a lot rather be with y'all in Austin, but thank y'all for doing that and all those type of things. So again, Robert, I think for sake of time, again, it's a new year. Got a lot of things happening, exciting things at JPS. We used to talk about things like an upcoming bond election. Isn't it great? All that's behind us. And now the opportunities of from that election are out there in front of this organization for the future. So a lot of great things to happen. So Robert, I'll turn it over to you for your CEO report.
Thank you, Mr. Chair. I want to thank Commissioner Johnson for the constant care that you give this hospital district. You are a liaison from the court, and we recognize that, and we appreciate it. It's always an honor when you come by here, but I'll tell you, Commissioner, the thing that we appreciate about you is how much you give back to the hospital district. I think a lot of people don't understand and know that, so I want to publicly thank you for that. And I think what you do to help us is pretty powerful. So thank you very much. Alice, thank you for allowing him to be here and be on schedule and sitting where he's supposed to be sitting. And Kelly, thank you for representing the commissioner. The commissioner and Kelly and I had the luxury, and Amanda, of taking a tour of our facility. And the commissioner was wonderful, going around the hospital and meeting the staff and talking with people. And she is, I think, going to be a nice asset in her caring way to the patients at JPS and the mission of JPS. When I talked to her in my office a little bit about where we were going and what we were doing, she's 10 steps ahead of me, and I appreciate that. So on behalf of us here on staff, and certainly I would think I would speak for the board, Commissioner Johnson, we appreciate you. And Kelly, if you would tell Commissioner Allen that we appreciate her and her ability to come here, and one of her first assignments was her dedication to JPS, and coming over and tour means a lot to us. So thank you all very much for being here. And to you, Amanda, and to you, Zim, I will tell you, just from a person who's not on the board, you're not going to find a better board. I would say that publicly, say it privately. They are good board members, and you will learn a lot from your colleagues, and they will help you. We as staff want to be here to help you. If there's any an acronym or initials that you don't know, if you will just wait one moment before you ask, Dr. Chuck Weber will already ask. There is not anything that we can put out there that is an initial that we don't have to defend and define for Dr. Weber. So you all will be assets to this board, and I think you'll enjoy it very much. But to our chairman's comment, if you think that you're going to have less work by being on this board, I would tell you what you need to do is not use caller ID, because I will call you often, and we will have you on various committees, and we will have you doing a lot to try to figure out how to make JPS better, which is all what we try to do. Most of your colleagues have blocked me out, so they know better. So I only have you two right now to call a lot. So I appreciate it very much. Leanne, I want to thank you, because you all need to realize that Leanne Franklin, in my book, walks on water. I know there's only a certain amount of people that can do that, but she does, and she's pretty amazing. We've had some tough situations at JPS here in the last month, and it's been really, really difficult for us to have any type of a challenge happen to one of our team members. It hurts, and we've lost tears because of it. We've held hands together. We've been up here oftentimes 24 straight hours trying to figure out why a situation like this could or would occur. And Leanne Franklin is a spiritual glue that keeps all of us. I don't really care where your spirituality is. Pastor, you know perfectly well, you've got an incredibly great congregation of people that listen, admire, and respect you. Leanne does that same thing, and she does it in an ecumenical nature. She does it for everybody, for those who believe, for those who do not believe, for those who have different feelings, attitudes, and mores. She's one of the strongest people I've ever been around, and she has been able to help a family through a situation they never would have wanted, expected, or thought they were going to go through. And there's no stronger person. So your prayer on a day like this is just what this group gets to see. What you do and pray every day to make this organization strong is really powerful. So Leanne Franklin, you deserve our applause. Chet Schrader and his band of incredible folks down in our emergency room have gotten an accolade well-deserved, in that we became an accredited geriatric emergency department. That's not easy to become. That is a tough population because of the nature of why they oftentimes come to our emergency room. Some of that population is challenged because sometimes they may be in a situation where a lot of things are challenging, such as parking, getting into the facility, the noises that are going to surround an emergency room, the lights, everything else. And to be accredited geriatric emergency room means we're trying to provide the right setting and the right type of care to our geriatric patients. So not only did Chet Schrader and the team and our nurses and the staff that we have in emergency qualify for that, and these are not, well, I'm not bragging, we are the only facility in Texas that has this, and that's not a brag, it's just JPS. So I'm proud of you, and I'm proud of your colleagues. If you would take that back for my thanks to the residents, if you'll communicate that to the nurses and the techs and all of your colleagues, it would mean a lot from us and the staff, and I certainly think I speak for the board that that's a neat honor to put on our wall of honor, one more thing that JPS has that distinguishes it from others. So, Chet, thank you very much. And Mr. Chair, if you don't mind, I'm going to give in the old vernacular of an old world I used to belong to, I'm going to give the balance of my time to Dr. Schrader in recognizing one superhero that we got here amongst many.
No question. You're not Spartacus, are you?
I'm not Spartacus.
So in the spirit of recognition, before we get to, I think we have a couple things on the agenda that we do need to request a board vote on, but can I take a moment and invite two practitioners?
You certainly may.
So Joseph Schneiderjohn and Elizabeth Smith. We blindsided them with this. We said, hey, just show up at 1. We're having a meeting. They don't know what's going on. You are welcome.
And
Have a seat.
There are no two people who dislike recognitions more than these two people. Yeah, I know. Oh, I know. And you were going to be right behind her.
Mm-hmm. So if I may, so the first person I want to introduce to the board is Elizabeth Smith. So Elizabeth has been with us over 12 years, was our first clinical nurse specialist ever credentialed at JPS. Elizabeth has been recognized in her work through our geriatric trauma program, which we affectionately call GT55. And also, she's been instrumental in APP retention, training, job satisfaction, wellness. But this year, I want to make sure the board is aware that Elizabeth was voted our 2018 Advanced Practice Professional of the Year.
Awesome. Chet, if you don't mind, if I could, Smith is a very common last name. Anybody in your family that has that name?
My whole family has it.
And before that, who had that name?
I am fourth generation John Pearson.
So
I
as
won't
much,
embarrass you anymore. I know you're going to kill me for that alone.
So it's her hospital.
It is.
so as much as Elizabeth hated that, I'm sure Joseph hates it even more. But I want to introduce you to Joseph Schneider-John. So Joseph's an interventional radiologist by training that I've had the privilege of actually working on cases with. I have stories that I'll forever be able to share. But Joseph's long since been respected by his peers. He was selected in our first TCU cohort as part of the physician engagement piece. And then he took, I think, the very, the not so fun job of our Physician Excellence Committee, which is our fancy way of saying peer review, and has really single-handedly improved the level of physician accountability at this hospital. So when we talk about quality programs, Joseph's the one driving it. And Joseph this year was recognized by his peers as our 2018 Physician of the Year.
Awesome. Wow.
So with that, I'm certain you are eager to get out of the spotlight. So we'll move on to the regular business if we may. Mr. Chair.
Thank y'all so very much.
Thank you.
Again, Joseph, congratulations to you, and Elizabeth, likewise, congratulations to you. And obviously in your family, the commitment and service to the mission of this hospital runs deep. So thank y'all both for being. Congratulations. Thank you.
Both.
Let's give them a round.
Just as an aside, trauma geriatric service last year took care of 900 patients. This year they're projected to probably be near 1,200.
Wow, amazing.
That's a lot.
I actually probably sold her significantly short in terms of that program. I mean, to my understanding, it's been recognized even by the American College of Surgeons as an ideal program, and is shared, through Chicago on a national level in terms of the things they're achieving. It's been amazing. All right, with that, I will pivot to business. In your packets, we have a request for approval of the Department of OMFS physician assistant privileges. And I would respectfully ask that the board consider.
Recommend approval.
I have a motion for approval by Dr. Weber. I have a second by Mrs. DeBose. All those in favor say aye. Opposed, no. Thank you very much. Chet, we will move forward then.
And I may need help with counsel with this if that's okay, but there was previously.
Yeah, let me.
Yes.
Please do. Thank you, sir.
Yeah, let me explain this. There are times when we don't have a board meeting and privileges come up for renewal, and in order to not miss a lick in terms of these physicians continuing to be able to have privilege at the hospital, the Joint Commission allows the chair and the vice chair on an interim basis to approve these privileges and then have them ratified at the next board meeting. And so on the first one, on January 9th, I have emails from Chairman Powell and Vice Chairman Weber approving this doctor's privileges in radiology and interventional radiology. And so, Mr. Chairman, you would need a motion on that one.
Yeah, I would need a motion. Do I hear a motion for approval? Reverend Emerson, I have a motion. I hear a second. Second. I have a second by Dr. Simmons. All those in favor? In fact, I guess we need to show Chuck and I abstaining on this.
No, you can approve.
Okay.
You can approve.
Then, based on the motion second, I will call for a vote. All those in favor say aye.
Aye.
Approved, no. Thank you very much.
Okay, and then the next item is also a similar circumstance. We have a number of doctors that are listed there in the agenda and various specialties that on January the 25th, I have emails from Chairman Powell and Vice Chairman Weber approving those privileges.
Again, I'd entertain a motion if there's no discussion. I have a motion by Reverend Emerson. Second. Second by Dr. Simmons. All those in favor say aye. Opposed, no. Passes. Okay. Chet, anything else?
Nothing further, Mr. Chair.
Wow, thank you so very, very much. And again, I appreciate your recognition of our outstanding employees. Thank you very much. The next item of business would be Dr. Hosberg. Is he here? Is Michael here? Oh, there he is, Michael. If you would please come up and give us a report from the claim physician group. Well, come on up and get this chair up here, Michael.
Thank you for the opportunity, as usual, to come up and say a few words about a claim. I didn't realize that Elizabeth was going to be recognized today. I actually had something on my agenda that was applicable to her, so I actually asked her to stay. Elizabeth has been instrumental in helping Claim and myself as we really develop our APP partnerships. Elizabeth serves as our Executive Medical Director for Inpatient Transformation. That is a parallel position to an Executive Medical Director of Population Health, which Dr. Nadia Lawe serves, and Jay Haynes, who is our Senior Medical Director for Innovation. Elizabeth, along with Kristen Stanley, have been working on developing a nurse residency, an APP nurse residency program for primary care. This is part of the larger strategy in relationship to retaining not just our residents, but obviously our nurses here at JPS that then go on to achieve professional practice beyond that. And so they are working on this particular project that we hope to launch for the August time period, which we would take 3 recently graduated APPs, put them through a mini residency type of program where they get mentorship in a variety of our clinics. And completion of that program, as well as acceptance on that program, would then require them to stay on as staff, as provider staff, within a claim for 2 years. And so it's Elizabeth, along with Kristen, have been really instrumental in putting that project together, and Elizabeth in particular has also helped on a number of inpatient quality initiatives, so she's been invaluable to me personally as well, along with the obvious recognition that she's received. Along a lot of those similar lines, Acclaim has finalized and approved their org goals as well as their service line goals. Within those service line goals, there are approximately 80 initiatives that cut across all the pillars of quality and population health and stewardship, all in alignment with the JPS organizational goals. And then there are a set of overarching Acclaim org goals related to, again, patient experience, retention rates, population health measures, particularly related to our JPS connection patient population, to ensure that we are achieving quality of care and improving outcomes surrounding heart attacks as well as strokes. 2 updates that I just want to give the board. One is in relation to our chair of surgery, or our service line chief of surgery search. We are in really the beginning phases, I should say. The search committee has formed. They reviewed and analyzed candidates. We have 5 stellar candidates that are coming in next week. That includes 1 internal individual. Any one of those candidates, at least on paper, we'd be really honored and lucky to have. We're going to interview those individuals and then narrow it down to the finalists, hopefully the final 2, bring them back in early March, and then hopefully have decided upon and be in contract with that chosen individual by the end of March. As another aspect of surgery, we just finished and finalized the successful recruitment of our first full-time vascular surgeon. This is an individual who will be starting in August, is finalizing her fellowship. And she wants to join Acclaim and JPS, in particular because of the opportunity to really create something here. And so that is one of the basic foundations when I look and hire and recruit individuals. I'm looking for dreamers, I'm looking for builders, and this particular candidate, that is really one of the prime reasons, not just the mission, but obviously the ability to create something special for our patient population. The last thing that I would add is our Acclaim Physician Board has been very much engaged and involved since the foundation of Acclaim, but in particular since the new board formed in around August. And they have recently recommitted to all the providers across Acclaim that Acclaim must truly stand for not just quality care, but also compassionate care and also character, things that a community can really be proud of. And that is something that they have messaged throughout Acclaim, and it's something that has been very well received. So it's been a start of a good year, and we look forward to more positive news.
Thank you, Michael. Any questions for Michael at this time?
That's great news.
That is great news.
the recruiting and whatnot.
Thank you.
Very much. Which take us now to item number 9 on the agenda, which is our committee reports. All three met on the 24th of January. We'll take I know he's going to say the most important one, but we will start with finance.
Since you said so.
Chairman Montgomery, if you'd like to proceed.
Yes, sir, Mr. Chairman. We had a finance committee meeting on the 24th. We did not have one in December, so we considered both the November and December 2018 financials. Ms. Clark is here to answer any questions or review those with you. We also approved 7 or 8 contracts for the full board's consideration.
Any questions for Steve at this time? If not, do we need a motion? We don't. We're just making reports. Item number B is
Sharon's got the.
Oh, Sharon's up. Oh, sorry about that, Sharon.
Sorry.
I thought everybody's new year.
Good afternoon. So you do have both months in your packet, but I'm just going to look at the year-to-date. December, as a reminder, our October 1st is our start of our fiscal year. So you're actually looking at a quarter when you look at the year-to-date numbers here. We have performed very well against our budget. From a medical center standpoint, our inpatient volumes have been strong. They've been just over 1% higher from admissions, and that has allowed us to outperform our budget by about $2 million. I always try to caution folks on counting. We're not going to be $8 million ahead by the end of the next 3 quarters. What's likely happening is about half of that is timing. We do have some savings from projects that have not started yet that I believe will be kicked off and well underway before we close the fiscal year in September. However, about half of those savings are permanent, I believe, because of some changes that we've made operationally that has allowed us to decrease some outside costs that we incur on behalf of our self-paying connection patients. So that's kind of how the medical centers performed. The Acclaim organization, kind of representing those professional fees of the physicians that are serving patients within our hospital walls and our clinic walls, their encounters are up by almost 3%. And they too have outperformed their budget by about $1.2 million. So for the first quarter, we're finishing up very strong financially, but there are 9 months left, and we will continue to see how volumes hold. And is there any questions that I can answer for anyone? We do cover these in much more detail at the Finance Committee for those of you who are new. So
They're a lot of fun.
They are fun, yes. All right, thank you.
Sharon, thank you. Steve, anything else you'd like to add? Sharon, thank you very much. Which will now take us down and to really the committee that does a lot of hard work. Mr. Bose, would you like to cover HR? Yeah, right. Dorothy.
We did have our meeting, and at that meeting we normally cover our scorecard, and we had a lot of discussion on our incentive plans. And so today we have several policies and stuff on the consent agenda. Okay.
Any questions, Mr. Bose? All right, then we will move to item number 10 on the agenda, which I'll ask Bill to come up. And
You want the quality committee?
oh, sorry about that. I guess we do need to cover it, Chuck. Sorry about that. I thought with Chad up there, we had that. Sorry about that. Go.
Trish is
Here comes Trish. Thank you, Tricia. How you doing? Thank you.
Trish, I've asked Trish to come up, especially when we get to the PS 190 report. But before we get to Trish, the committee met and we had 12 policies that were approved. Laura Burnside gave her performance improvement report and updates, but just for the new members and for the community, the patient experience updates, there are about 10 of them, and there's dimensions of care with care transitions, communication with nurses, communications about medicine, discharge information, overall rating of the hospital, communication with doctors, cleanliness, quietness, communications about pain, responsiveness of staff, and would you recommend the hospital? And that's an ongoing study by, it's not really a study, but survey by Laura. And then she also presented the outpatient goals, and there are 10 questions in that, and that really is designed for the primary care clinic, specialty clinics, and the women's health clinic. There was another presentation on antimicrobial utilization, and that's essentially antibiotics and are they used appropriately, et cetera. And just for sort of statistical stuff, 30 to 50% of antimicrobial use in the United States is unnecessary or inappropriate. That's a lot. There's a lot of collateral damage that's done when the antibiotic is not appropriate, et cetera. There's drug resistance, adverse reactions, as well as other infections that can arise. And another thing that happens is it helps preserve the current antimicrobial spectrum and also protects new agents as they come out. So if they're not used right away or inappropriately, they don't develop, patients don't develop, bacteria don't develop resistance. So it's even more important. And this group's doing a good work. And their goal is to optimize clinical outcome and patient safety, but as part of the three-legged stool, it's also designed to decrease or control cost. And then the last part was for Dr. Tricia Swift.
Thank you. Good afternoon. Good afternoon, everyone. Thank you for allowing me a seat at the table today. I'm going to review our PSI 90 organizational goal, give you a little bit of background and information on that. So PSI 90 is a composite score for how we measure harm in an organization. It's an evidence-based standard that was developed through the Agency for Healthcare Research and Quality. And this particular metric is involved in many of the reimbursement programs that we hear about when we talk about how governmental and accreditation agencies measure quality. It's basically a composite score of 10 metrics. Those 10 metrics roll up to one number. It's measured by number of events that are expected over number of events that were observed. And so it's a way to factor in known risk factors for patient populations instead of just going with simple counts along a spectrum there. It's also risk adjusted based on severity of harm. So what that means is there's metrics within the composite score that have a heavier weighting based upon how severe that event would be to a patient. You'll see what those weightings look like here. This is the graph of how PSI 90 is measured. And as I mentioned earlier, there are 10 events rolled up into this measurement. And it includes things that we are used to monitoring within a quality program, such as pressure ulcers and falls with injury. But it also introduces some more detailed metrics related to the perioperative patient population, where we look at prolonged ventilation after surgery, we look at wound healing, and we look at punctures and lacerations. So the three heaviest weighted metrics within the measure are post-op respiratory failure, as I mentioned, perioperative DVT and PE, and that really represents blood clots.
Why don't you explain what DVT and...
Yeah, absolutely. DVT and PE represents blood clots in the surgical environment. So whether that's located in an extremity, like a leg or an arm, or whether it's located in the lung. And then the other most heavily weighted metric, as you'll see, is postoperative sepsis, which really represents an advanced infection after surgery. So we've introduced this metric to the organization for our annual goal in the quality pillar. As I mentioned earlier, this metric is measured in a ratio for what we expect to see over what we actually saw. So that would make the target would be 1. If we were expected to have one event and we had one event, our score would be 1. It would make a stretch goal of 0.88, which would be representing performance better than expected, and a threshold of 1.2. Our fiscal year-to-date score is 1.3, so we are a bit over where we are targeting to be, but continue to prove month over month as we are zooming in and working on better understanding where our opportunities lie with this particular metric.
Just on a magnitude of scale, how far is 1.3 from 1.2?
So, yes, good question.
What school did you go to?
I was a Red Raider. Yeah, I think go on hard on that one.
Yeah, Steve.
You can't.
Thanks, Steve.
First of all, tune out all the Aggies.
Sure.
Red Raider will give you advice.
I mean, quantity of scale, I mean, is that, you say a little bit, I mean, but
Yeah.
it looks like between baseline and stretch is not a big, a big stretch there.
Yes, you're right. It's really hard to move these numbers, and so that's why you don't see a huge upper and lower control limit here. So for those of you that like math and like numbers, our threshold and our stretch in this particular goal represent one standard deviation from our average, and so that lets you know kind of where our scale is on that. And so it's
a composite of all those metrics.
It's a composite of all those metrics together.
And those metrics are given to us by, I mean, those aren't, the 25.52% is standard among all healthcare providers.
Right. So that's the benefit of using PSI 90, because the metrics and the weightings are standardized across the country. So we're able to compare ourselves to other organizations. We're able to drill down to the unit level, to the provider level, which gives us a level of visualization that we haven't, always had before with quality and measuring harm.
So how does our 1.3 measure up to everybody else?
So everybody else is measured with a score of 1.
Okay.
Right. So that's the other unique part about PSI 90 is it looks at our specific patient population. It says based on your population, this is what you should see from an event standpoint. So we are above at the moment for where we want to be at a target of 1. But as I mentioned, we're seeing that number already starting to tick down with the focused efforts of our physicians and our nurses and all of our clinical staff. So I definitely see a lot of improvement on the horizon. Any other questions I can answer? Great. Okay, thank you.
Chuck, anything else?
Nope, that's it. Thank you, Chris.
All right. Trish, thank you very much. And he got himself in trouble with his comments, but you helped him out by saying he was right. He got his ego back. Yeah, we did note for the record that she said you're right on the other matter. Thank you again. That'll take care down to agenda item number 10. And at this particular point in time, Bill, you would come up and the UT Southwestern Moncrief Cancer Center Service Agreement.
Sir, good afternoon. I've asked Dr. Duncan to join me. All of you know Dr. Duncan, except for maybe some new board members.
That's right.
Karen is a pediatrician by training. She has served SNFs at Cook County in Chicago and Grady in Atlanta. And I can't tell you how fortunate we are to have her. Somewhere along the way, someone was able to convince her to join us. Probably Robert. I don't care, it's fine. She's a tremendous leader. And I have made the decision to transition the women's clinics to Karen and her team. And those women's clinics include mammography. For the most part, we don't do screening anymore, but we do diagnostic mammography. So I wanted to explain why she was here, and she could answer any questions that perhaps some of you might have as a result of this proposal to you to consider today. We've been working on this for some time with Moncrief, and this formalizes the agreement that we have structured with Moncrief to provide all of our mammography screens at the district. So this is budgeted about $1 million in our fiscal year 19 budget. Moncrief will bill for those patients who have payer sources,
and the offset we anticipate will be somewhere around $300,000. So we have the money in the budget to provide this service. They can't provide it all, but this is a significant portion of the mammography screens that are in the district today. And as a result of Dr. Duncan's work and her team's work around improving access, which you all know is an opportunity and a challenge we have each and every day at JPS, we were able to see 30,000 plus more patients in our primary care clinics last year than we have before. So that results in additional mammography screens and orders, right? So this is our recommendation to you to consider formalizing and allowing us to execute this agreement with Moncrief Cancer Institute to perform mammography screens for the district to the extent that they can accommodate our current volume. Be happy to answer any questions any of you might have. Or Dr. Duncan.
Just with the buses type.
So that includes fixed and mobile.
Right.
Yeah, fixed and mobile.
Their fixed site is on Magnolia, as you know, within the Moncrief Cancer Institute building itself. And the other screens will be mobile screens that they'll rotate among all of our clinics.
And to Chuck's point, we have not purchased any additional mobile units at this time. We are able to use Moncrief's mobile unit. We would come to you if we decide to go in an advanced level of mobile care. We will look at that at a later date. It's giving us the ability to really have the luxury of Moncrief and seeing how that works, and then seeing what level of mobile units we want to be involved with.
That's good clarification, Robert, because the board had discussed.
Right, and we have discussed it, and that is still a real, that is a potential out there.
I appreciate the clarification, because we had talked about that. But at this time, this is straight with Moncrief.
Yes.
Yes.
I noticed in the contract, we have a review of the number of, how long it take them to get an appointment. But I did not see anything that they would be reporting back to us on the service time once they get there. It looks, against the contract, but I would think we would have something in there to monitor that when our patients go there, there is a timeliness of service there, that would be part of the routine report.
It's part of a dashboard that we review routinely, and Karen can explain those dashboard metrics if you like.
There is a survey currently that Moncrief is sending out to all
Bill,
the
move
patients.
that mic over for
There is a survey that Moncrief provides for all patients that they service. You did approach me about that, and so I did a little bit of research in that short period of time. And we have, with the new interface with Epic, we will be creating our own survey that will look at timeliness to appointment, timeliness through the visit, and also respect that's given. So those will be three top things that we'll look at, and we'll be glad to.
My final question is, do they send a report to our patients, when they have a mammogram there, the diagnostic one? Usually you get a letter, even though they send one to the doctor. Is that a part of their
requirement? It is, yes.
Okay.
Whoever takes that mammogram is responsible for reporting those results. Those results, now with the new interface, which is this week, will go directly to the doctor and in more real time.
No, is there a specific time frame that the patient will be notified of that diagnostic report?
So usually those reports are completed within 24 hours, and so within about 2 to 3 days, the patient is receiving the result.
And these mammograms are referrals from our diagnostic mammograms on campus, or through our system.
Screening or through our primary care providers.
And then they refer to Moncrief. Is that how this works?
The orders for the mammography screens from our providers are scheduled by our staff at Moncrief, whether it's at the permanent site or a mobile.
Okay.
Right? And we keep statistics by site as to how long it takes for the next available appointment. We have a lot of no-shows, approaching 30%, that did not keep their appointments, and that's always been a challenge. From a diagnostic perspective, we track from the time that mammogram is completed in red as to how long it takes them to get into a diagnostic appointment. And if it's beyond 7 days, then those patients are seen elsewhere. So we have an obligation, an opportunity, and a challenge to get those in as quickly as we can.
You think? Go ahead, Ralph.
Yeah, I am in support of the contract. I'll say that up front. And this question might be for Michelle more than the two of you. But I've mentioned this before. When we get to the MBE, WBE compliance, that I'm aware that this contract, the company, the services are excluded, but maybe it would be helpful if you check the other block also, because I'm quite sure that they are in compliance with our MBE, WBE. So as opposed to just checking it's an excluded, I think we ought to do both.
Okay.
With that.
Good point, Ralph.
Okay. Good question. I just want to applaud administration on this. I know a lot of work's gone on into this, and this is a great example of us working with our partners in the community, especially as we go forward with our bond expenditures and how we can partner with assets and
Thank you.
provide better care.
Yeah.
Thank you.
This was an issue that administration brought the board, and we had an issue, and we took that issue and turned it around to something, obviously because of the work, that turned out very positive. I think we're getting better across the
Well, more to come.
It's
More to come. We're
right.
looking for some more partners because they can't handle all our volume.
Yeah.
That's
We're looking for more mobile. One of the great things with the mobile is that we can really go to where the patients are at.
Yes.
We currently went to True Worth. We had 70 women on schedule. Close to 40 actually showed up. We were able to do their pap smears, their mammograms, so really getting closer to the community.
Yeah.
And so looking for more mobile that we can send out.
Is that part of the strategy to reduce that 30% no-show rate or to help you?
You know, we've attempted to overlook to the no-show rate. I will tell you that if all of those patients show up, the experience goes down because you're trying to move through more patients within the same period of time. So we struggle with that. We've had conversation with Moncrief about that. So we do a little bit of overbook in attempt to handle the no-show. More importantly, what we do is to use our patient care coordinators to reach back out to those patients and to educate them on how important it is for that screening.
Amanda, part of the problem and the challenge that we have is in certain sectors, just certain ones, because it's not a reason for all, but when you look at particularly our True Worth area and some of our other areas where you've got a very transient population coming in and going out, Monday to Wednesday is a lot different than the Monday to Wednesday in maybe other people's schedule. So sometimes when you book for 70 and 30 show up, we're actually pretty excited. To Dr. Duncan's point, if all 70 showed up, it'd be a challenge. But then we don't want 10 showing up. So the nimble nature, I don't know how those people have hair on their heads because they just got to pull it out every day because it's so frustrating. But at the same time, you got to book to the no-show rate, and it's hard. So my compliments to y'all on no-show rates.
DT?
It's probably will tie into your population health, manual visit, and all that stuff that tie to the star rating.
Say that again, DT.
Oh, it's just follow up to the. I want to make sure that we have a closed loop so that it can be reported back to the system later on for your star rating and all that stuff. Because when you order like that, are they transmitting data back into our system for potential reporting on the?
So the report is transmitted back. Is that what you're asking? So when that screening is completed, it is transported back. And we also have the ability with our blocking on our Epic, in which we can, Epic Care, no, the Epic Care, in which we can go out, and we did quite a bit of that work in going out and looking through our queue and seeing if there were patients who actually had already had their mammogram done at other sites here in Tarrant County, and we were able to find about 1,400 within that queue that had already had theirs, and we were able to pull those reports and scan those in. But for those that are being done by Moncrief, that report is sent directly back. Does that answer your question?
Yeah, because I'm more worried about the patient registry down the road when you're doing the rating, the annual, what they call quality reporting type thing down the road as you move more and more forward to the kind of value-based care, because of making sure that you can point and attribute it back to the right group down the road. Because I think some of the contract going forward with value-based care for Medicare MSSP or something that you may be looking at down the road. We want to close the loop on that one.
No, I think it is important for us to look in that.
Okay.
Anything else for any? Yes, I got a motion by Mr. Petty, second by Mr. Montgomery. All those in favor say aye.
Okay, thank you very
Bill,
much.
thank you very much. Dr. Duncan, thank you very much for what you're doing. Thank you so much. Which would take us down to item number 11, which is the consent agenda. I know most of y'all have had plenty of time to look at that on the portal here. I think, Neil, you needed to make one comment.
I just want to make a
prior
comment,
consent.
to the two new board members. You see a number of policies, and then you'll see a procedure that follows. You as a board approve the policies. The procedures are what the administration has done to implement that policy. So they're there for your information, the procedures are. But what you're approving as a board member is the policy itself. Okay?
Move approval.
Have a motion for approval by Reverend Emerson, second by Mrs. DeBose. All those in favor say aye. Opposed? Carries. Thank you very much. Which would take us down now. I think we have a couple of items for executive session, and
I've got a couple of things.
You need legal? Okay.
Yeah, under the general counsel's report, there were no contracts this past 30 days that were between 200 and 500,000. This is the time of year, February meeting, that I provide you the general counsel's annual report, and I'll hand that out and give that to you as you go to executive session. If you got any questions, feel free to call me. The other thing that I will hand out, back in 2011, Trent Petty and I sat down at his suggestion that we negotiate some of our fees to a monthly retainer. And Trent, through since 2011 was a part of a fiscal year, but through the 28 fiscal year end in September of 2018, there's been over $520,000 saved by implementing that retainer that otherwise would have been charged to the district. So, and that completes my report.
Okay. Mr. Adams, is there anything else before we go to close? Then we will, let's take about a 10-minute break, reconvene here about 2:10 and close, and we will end open at 2 o'clock. Thank you. decision what they do, but why in the hell would you sign a big multi-million-dollar, multi-year contract with these people right now? We're fixing to pull from it. If that's what the board, I think that's what the board would support Robert doing. I mean, after all this.
DT, you had 301.
You did good, DT. If I can get everybody's attention, we will now reconvene an open session at 3:06. And I'll ask General Counsel, Mr. Adams, I think you have an issue that...
Yeah, the board needs to approve a motion, make a motion to approve the mediated settlement on the Priscilla Armity case.
I have a motion for approval. I have a second. Mr. Bose. All those in favor say aye. Aye. Opposed, no. Thank you very much. It passes. The next item, Dr. Schrader, I'll turn to you for privileges.
Discussed in closed session, the board has a copy of the medical staff credentialing activity for the month of January, and would ask consideration for approval.
I recommend approval as presented by Dr. Schrader.
I have a motion by Dr. Weber.
Second.
I have a second by Dr. Simmons. All those in favor say aye. Aye. Opposed, no. Thank you very much. It passes. Is there any other business that needs to come before the board at this time? Then there being none, we will stand adjourned. Thank y'all very much.